and welcome to Public Health Live, the third Thursday breakfast broadcast. I'm Rachel Breitster, and I'll be your moderator today. Before we get started, I would like to ask that you please fill out your online evaluation at the end of the webcast. Continuing education credits are available after you take our short post-test, and your feedback is helpful in planning future programs. We encourage you to let us know what topics are of interest to you and how we can best meet your needs. As for today's program, we will be taking your questions throughout the hour by phone. The toll-free number is 1-800-452-0662, or you may send your written questions by email at any time. Please email us throughout the hour at phlive.ny@gmail.com. Today's program is Prediabetes, How Healthcare Providers Can Take Action. Our guest is Dr. Jill Abelseth, an endocrinologist and director of Capital Region Diabetes and Endocrine Care with St. Peter's Health Partners in Albany. Doctor, thank you so much for being here.
Thank you for having me.
So to start off today, can you give us some context and talk about the obesity epidemic that's going on across the country?
I think you're defining it perfectly. It clearly is an epidemic. And really what this picture is a picture of evolutionary success. Because as technology develops, we become more attached to our laptops, our computers, Facebook, and all of our iPhones, all of those things, and we become more sedentary. So in the past, people would actually exercise as part of their daily life.
Sure.
Now we have to choose to exercise. Actually, also we're becoming more attached to fast foods in our busy life as we're becoming more economically challenged, and this is the picture that we see.
So we've got this obesity epidemic going on across the country. Does this obesity epidemic, does the risk factors vary state to state and by different types of population?
Sure. As you can see depicted on the screen, this is a slide actually of self-reported obesity among non-Hispanic white adults by state. And it ranges from about 15% of that group to greater than 35% of the population. As we then look at non-Hispanic Black adults, you can see the prevalence is much greater. And then as we switch to Hispanic adults, there is a difference as well. So clearly there's an ethnic variation in terms of the prevalence of obesity.
Now, in addition to having varying rates by race and ethnicity, have these rates changed over time?
Absolutely. So if we look at this slide, which is the age-adjusted prevalence of obesity and diagnosed diabetes in U.S. adults, and this is from 1994, you can see obesity described as a BMI greater than 30 and then diabetes. As we follow along and move ahead 6 years to 2000, you can see the incidence of both obesity and diabetes has dramatically increased. And then as we get to 2010, clearly, it's shocking how much obesity has increased. And I think it's clear from these slides that the diabetes epidemic clearly mirrors the obesity epidemic.
Now, can you tell me a little bit about the impact of diabetes in New York State and nationally? Because you've shown it's growing. So what impact is that having on us?
Well, clearly, there are about 29.1 million people in the United States. That's about 9.3% of the population. And remember, this is 2012 data. It's not even this year that have diabetes. And we in New York State, we're not immune to the epidemic. About 1.5 million adults, 10.4% of the population have diabetes. About 971,000 or 7.5% of New Yorkers have prediabetes. And as we go forward, I'll explain to you what that means. I think one of the most frightening aspects of this is much of the population do not recognize that they have these disorders.
That certainly is something to be concerned about and to be aware of. Now, are there notable differences in diabetes diagnoses across New York State?
Absolutely. So as we look, you can see there's a difference as we look across the state in terms of adults who have been diagnosed with diabetes. So there's certainly pockets in different areas of the state where the prevalence is higher.
Now, what does this large rate of diabetes mean? Or in other words, what's the financial importance of the discussion we're having today?
I think that's a good point. It's clearly important to the individual and their families as far as the medical aspects go, but this is an economic crisis for us. So in 2012, again, 2012 data, $245 billion was spent on diabetes. That's 11% of healthcare dollars. Now, $176 billion were in direct costs, and you might ask, what's the rest? And in fact, indirect costs are loss of time from work, disability, premature death. So this is clearly a growing epidemic that's going to affect us economically.
And I think that point that you make about the indirect costs, those are things that we often don't even think about. So this is really, really staggering. Now, can you talk about New York State Medicaid specifically and those costs?
Absolutely. So New York State Medicaid is spending about $10 billion on patients with diabetes. That's the B word, billion. And this is 2011 data. Keep in mind the majority of these patients have more than one associated health condition. 60% have two, and 28% have more. So diabetes does not usually occur alone. It usually lives with hypertension, cardiovascular disease, and other illnesses.
And as we see more and more of those co-occurring illnesses, the health costs are then going to increase as well.
Absolutely. Good point.
So clearly we can see there are these enormous costs that are incurred. Can you help us understand what does this mean for the individual patient?
Yes, I thought I'd tell you about a patient that I've actually seen in my practice in the past 6 weeks. This is a 66-year-old woman who's had type 2 diabetes, probably diagnosed for 15 to 20 years. She's been with us about 6 weeks in our practice. She's on what we call MDI, which is multiple daily injections of insulin. So she has to take 4 to 5 injections of insulin a day to keep her blood sugars where they need to be, and she's not being successful. And we're not being successful. Her A1C, which is we'll talk about, is her average blood sugar, is 12%. That's very high. So associated with that, she has the complications of diabetes. She has eye disease, nerve disease, hypertension, cardiovascular disease, and because of that, it's almost impossible for us to effectively treat her.
It's a really important picture that you paint in showing what the individual patient looks like and how this becomes such a serious situation. So as someone continues to progress with the disease and encounter more and more related illnesses, talk about how the cost then escalates for the individual.
Well, you can see how the cost will escalate when you talk about first a patient presenting by being overweight, then over years they develop obesity, and as we talked about, there's a direct link between obesity and diabetes, so they develop diabetes. We know the complications of diabetes occur anywhere 10 to 25 years after diagnosis, and then they deal with what we call the microvascular complications of diabetes, which are eye disease, blindness, kidney disease, dialysis and renal transplantation, which of course is very costly. And I also want to make the point of cardiovascular disease for two reasons. One, because in a patient with diabetes who has neuropathy, underlying ischemic heart disease can be silent and they might be unaware. And cardiovascular disease is kind of the silent killer in these patients. And I tell my patients with diabetes that it's an equivalent risk factor. And what does that mean? That means that if you are a patient with diabetes, you have the same risk of having a heart attack as someone who doesn't have diabetes and has already had one heart attack. So this is the killer of our patients with diabetes.
Wow, that really is kind of a startling piece of information.
It's a strong message.
Absolutely.
Strong message.
Now, so you've provided us with a good idea and a solid understanding of the enormous costs, both for the individual and the bigger picture. Can we take a step back and talk about the prediabetes epidemic and what that means? What does that look like?
I'd love to. This is important, and this is absolutely why we're having this broadcast today. Before diabetes is prediabetes. This is a huge population, both in the United States and in New York State. Of particular note is the lack of awareness, both among clinicians, caregivers, and patients about prediabetes. 4.5 million adults in New York State have prediabetes, but very few know about it. Why is it important? Because without changes, many of these patients will progress on to develop diabetes within 5 to 10 years. It's also important to note that many of the problems they develop can actually start during the prediabetes time, and by that I mean eye disease and heart disease.
So those are starting even before a diabetes diagnosis.
Absolutely.
So from what you're saying, looking at the numbers of prediabetes and diabetes, I mean, they're pretty staggering numbers, and it sounds like those folks who are actually diagnosed with diabetes, that's really just the tip of the iceberg.
Absolutely is. When we look below the surface, we see the staggering epidemic of prediabetes.
Now, how do clinicians identify prediabetes?
Excellent question. And I think this is a very important point. There's basically 3 ways they can do that, and they can choose which way is easiest for them in their office. The first way is a plasma glucose, which they could obtain at the time of physical exam. The patient has to be fasting. We know normal is defined as less than 100. Diabetes is defined as greater than 126, and prediabetes is in between, so between 100 and 126. If they have an oral glucose tolerance test where they actually are given a drink of glucose and then glucoses are measured afterwards, we look at the 2-hour after the drink glucose, and in fact, if their glucose is between 140 and 200, then they have prediabetes. Less than 140 is normal, and greater than 200 is diabetes. The other and perhaps easier way is to look at something called the hemoglobin A1C, which is the average glucose.
Okay.
It is considered to be normal. If it's less than 5.7, diabetes greater than 6.5, and prediabetes if it's in between.
Okay.
Lot to remember.
Certainly. Luckily, we've got the handouts that folks can
Right.
download and go see their physician for more information. And we'll talk about how people can get all of this
That sounds great,
information.
yeah.
So are there specific ways that doctors can diagnose prediabetes that can help predict type 2
I
diabetes?
think that's a good question. I think we have to look at the continuum between prediabetes and diabetes. And what you can see as you look at this slide is the first thing that develops is insulin resistance. So people become resistant to the insulin their body is actually making. Over time, their pancreatic beta cells that make insulin can't keep up with this insulin resistance, and in fact, insulin levels start to fall. And when insulin levels start to fall, glucoses start to rise, both at the fasting time and at the post-after meal, postprandial time. And this process occurs perhaps 5 to 10 years before they actually develop diabetes.
Interesting. Now, does understanding these dynamics help doctors to prevent the disease progression, or is there an optimum time for prevention?
Clearly, what it's giving us is an opportunity, because if we can make a diagnosis prior to the development of diabetes, in the pre-diabetes time period, we can treat more aggressively, more easily, and perhaps delay or stop the progression to type 2 diabetes. This is a huge window of opportunity.
So it's not an automatic sentence.
Absolutely not.
Great. So what is the standard recommendation now for screening and identifying prediabetes?
Well, let's start by reviewing again why we do it. We know that type 2 diabetes, as we talked about, is a very serious disease for the patient.
Sure.
It's very costly. There's an asymptomatic phase, which is not benign. Early complications can be developing, and we know that early treatment actually prevents those long-term complications that we talked about.
And can you talk about the criteria for screening for prediabetes and type 2 diabetes in individuals who are asymptomatic?
Okay, so we have to screen because patients are asymptomatic, and so we want to look at risk factors. Who can we pick to screen? And risk factors are physical inactivity. If you have a first degree parent, sibling with type 2 diabetes, if you have a high risk race or ethnicity, and we reviewed what those are, if you had diabetes during your pregnancy, that puts you at a huge risk. If you have hypertension, defined as a blood pressure greater than 140/90, all those patients should be screened. So other risk factors include HDL less than 35, that's a cholesterol factor.
Okay.
Your A1C that we talked about, greater than 5.7, and other clinical conditions that have been associated with insulin resistance, such as polycystic ovarian disease in women. If patients have a history of cardiovascular disease, they're of significant risk. So clearly, most people have one risk factor.
Yeah, it certainly sounds like it.
Yeah.
That's a fairly long list of potential risk factors. So can you explain the provider decision-making process for screening a little bit more?
Absolutely. So every adult who has a BMI greater than 25 should be screened if they have an additional risk factor. I'd like to make the point that if you have a patient who is an Asian American, that's just been changed to a BMI of 23. If they have no risk factors, then the latest they should be screened is at age 45. And we have to look at it like we do a colonoscopy. We screen for a colonoscopy at 50. No risk factors, screen at 45. If they're normal results, then you're going to repeat screening on a regular basis, and you're going to use your clinical judgment to determine how quickly do I need to rescreen this person, and if they have prediabetes, you need to intervene and test on a regular basis.
Now, can you talk about the impact of diabetes on pregnant women?
Okay. So remember, gestational diabetes, which is defined as diabetes that develops during a pregnancy, it occurs in about 10 to 11% of women, and it occurs because the placenta makes a growth factor for the fetus that goes to the mom and affects her glucose control. It's actually counter-regulatory or opposite to insulin. So about 10% of women cannot overcome this, and they develop glucose intolerance during pregnancy, which is universally screened for. Because this pregnancy is just a stress factor, when the pregnancy is completed, the gestational diabetes goes away. Then as they age, as they gain weight, other stress factors occur, they are at huge risk for developing diabetes. So this is a very select population we need to monitor.
So having gestational diabetes puts you at greater risk for diabetes later in life?
Yeah, and the statistics are anywhere from about 2.6% to almost 70%. And some of that's based on what their glucoses were, what their race, ethnicity, family history of diabetes, all those play a role.
See, now that's really interesting. I had no idea that the two were related.
Yeah.
Now, can you describe the tests that are used to screen for diabetes?
Yeah, there's several ways to screen, and we kind of went over them. So the three that we can use is fasting glucose, which is perhaps the easiest in the office at the time of a physical exam. The 2-hour glucose tolerance, which we described, is really the gold standard. So if there's any question, we want to do that test.
Okay.
But it's tough for the patient. They have to be fasting, they have to drink a glucose load, and they have to stay in the lab or the office for 2 hours. So it's kind of difficult. The other is a hemoglobin A1C. The benefit of that is it doesn't have to be fasting. It can be done at any time.
And is there more information about the various types of tests and what they reveal?
Okay, so we reviewed it before, but this is a quick cheat sheet in terms of how you diagnose normal, prediabetes, and diabetes in terms of the fasting glucose, the post-challenge glucose, which is only the 2-hour post number, and the A1C, and you can see them described there.
Great. Now, a question that I think would probably come to mind for a lot of people, and I think you know,
I know what you're
going
going
to
to ask. I know what you're going to ask.
Is the costs. Are these tests covered by insurance? Do people get reimbursed for them? Because I think healthcare costs are a barrier for a lot of people, and if we're trying to really impact and get people aware of this, talk to us about the insurance factor.
I think this has clearly been an issue for clinicians. They've been hesitant to do these tests because they don't know how to get paid for them, and they're afraid the patient will have a heavy bill associated with them. But we do have codes. So we have ICD-9 codes for prediabetes testing. The one that we use most frequently is 790.21, so you can use that. But I have happy news, and the happy news is that as the new ICD-10 comes out later this year, there's actually going to be a code labeled prediabetes. So even the coding people are understanding the necessity of doing this.
Excellent. That sounds like a great step in the right direction.
Absolutely.
Now, so we can talk about, all of the costs and this staggering burden, but I think what we want to start to get to is what are the best treatments for prediabetes?
Well, clearly there's two. One is lifestyle intervention, recommended to lose 5 to 7% of the body weight, which would be about 10 to 14 pounds in a 200-pound person, and at least 150 minutes a week of physical activity. The second thing we can do is use medications, and we'll talk about that as we move forward.
Now, has there been research on the different strategies, whether we're talking about losing weight and increasing activity versus doing a medical intervention? is there research that tells us the results of those two different types of approaches?
Absolutely. There have been multiple studies, and they're called prevention trials. Can we prevent diabetes? And the diabetes prevention program is actually in this country, and they found that they reduced the progression to type 2 diabetes by 58% and 71% in those over age 60. Keep in mind, if you look at those over 65, then it's 27% of the population, so that's an important group. And I think important information is it was consistent across all ethnic groups. So it didn't matter if you were an African American or what your ethnic background was, you had the same benefit. Blood pressure, lipids, the comorbidities improved. And I think the really important factor is when they looked further on, 10 years down the line after this was done, the benefit continued.
So it wasn't the sort of thing that we see an improvement and then the gains are lost over time.
And that's so important, I think. Yeah, absolutely.
So is all of the research that's been done focused on clinical providers?
No, because we find that in some of our populations, those perhaps who are economically challenged, they either don't want to go see their physician, they don't have access to a clinic, they're afraid of a hospital setting or a physician, they don't feel comfortable, they can't get transportation, so they have a lot of barriers. And in fact, they found that lay workers, community workers in WISE community centers can be just as effectively trained to deliver this information and program as clinicians.
That's really excellent to hear. Now, can you tell me a little bit more about the diabetes prevention programs?
Okay, so the diabetes prevention programs are these group programs, which we mentioned. They teach patients actually how to make lifestyle changes. They offer teaching support. They're usually group classes. They occur over a 16-week period. For example, classes might include how to measure a portion, how to read a label, how to break down barriers. What's stopping you from eating correctly? Do you not have access to healthy food, only access to processed food? Do you find it difficult to exercise? Do you have trouble with child care? And if you slip off, how do you get back on track? So you can really see how that would be really valuable for the person attending.
Absolutely, because I think even in conversations with people, you know, in my network who maybe aren't at risk, people tend to be so unaware of what is a serving size and what does that look like. And we go to restaurants and the portions we're given, I mean, that's enough food for probably 3 meals.
You're absolutely right.
And if people aren't aware of that, providing that education is critical.
Right. I think that's really important.
Now, it looks like the CDC has recognized many programs throughout the country, but New York State's sort of at the front of things in terms of the programming that we're offering. Can you talk about other ways that New York State continues to build this infrastructure that makes our state so strong in diabetes prevention?
Absolutely. We should be very, very proud of New York State and what it's accomplished. In addition, the state's public health partners provide information for medical providers. So linking the healthcare system with the community program delivery. So what that means is they're going to provide information to clinics, providers, hospitals, and show them where their patients can go to access these programs. So that'll be great.
Excellent. Thank you. Now that we've heard about all the opportunities to prevent diabetes and diagnose prediabetes, let's take this opportunity to hear from Lisa Ferretti, the Executive Director of QTAC, an organization that works to support evidence-based health promotion and disease prevention programs.
The National Diabetes Prevention Program is an evidence-based approach to helping people to reduce their risk of developing type 2 diabetes. It was developed through a National Institutes of Health study, and the data from the study, and this is held over many, many years since in the longitudinal data, has showed that people who reduce their weight by a modest amount by taking this program and increase their physical activity to about 150 minutes per week on average were able to get a risk reduction of somewhere between 58 and 71%. It's a program that's promoted by the Centers for Disease Control and Prevention and has a national support network around the country to help people to deliver the program and to target people who could best benefit from it. So in New York State, we have multiple delivery sites for the program. The National Diabetes Prevention Program right now geographically is spread across about 50% of the state. So that means that 50% of the population of the state can access the program. So it's actually, there's coaches in more sites geographically, but there's less population in some places. So we're covered about 50% of the state right now, but we can always build and are continuing to build that infrastructure. The program is delivered in multiple types of sites. So it can be delivered in healthcare settings, it can be delivered in community-based settings. So if you're a healthcare provider or a health office or a healthcare clinic and you're interested in finding ways for your patients to participate in a National Diabetes Prevention Program, or Y DPP, the best thing to do if you're looking for Y programs and there's a Y near you is to contact that Y and find out if they're participating in the intervention. If they're not, or if you want alternate types of places for people to take the class, you can come to our website at QTech New York, find a workshop, and you can type in the zip code of the participant that you're looking to, the patient that you're looking to be a participant, and you can find out if there's a class happening near you. If there's not, you can type in information into that system that will push information to us here at the QTech. We can be in touch with you and with coaches in your community and try to help you to generate a workshop in your local community. We are interested in how the programs are being disseminated across the state. So one of the things that we do here at the QTech is to collect some data about the programs, where they're happening, who the coaches are, what type of organization they're being delivered in, if people are charging a fee or not, if the program's being reimbursed or not, and other information about the participants, like what the eligibility, what made them eligible for the program, why they came, some basic information about them demographically. And then also we collect weekly session data, which helps us to understand if the participants are on track for losing weight and increasing their physical activity. So all of the data that we collect, or that our coaches collect on site, is entered into a secure online portal that we call Compass. It's our data portal, and it keeps track of all of the participants and all of the classes that are happening around the state for organizations that are linked with us. And right now we have about 50 different organizations around the state that are delivering the NDPP, and they probably represent about 200 to 300 different delivery sites potentially for people to take the class. So all that data is held securely in this HIPAA compliant server. We are also working to build into that a feature that will allow physicians to make direct referrals into the program and to get feedback about their patients from the program, either into their electronic health record or even just through an e-fax. But so the doctors really know that when they refer people to the program, that they're really taking the class and they can really see, without having to wait till their next appointment, whether or not folks are actually making progress in the class. When we look across the board at participants who are the most likely to complete the program, so stick it out for the whole year and achieve those goals, there is one really striking thing that we see. And that is that for participants who actually have a physician blood-based diagnosis of prediabetes, we see much higher rates of completion of the program than we do for people who screen in just based on risk factors. Now, I don't think that means that people who screen in because they're at high risk because of obesity or family history or other things, that they don't do well, simply because, they're at high risk and don't have a diagnosis. But I think it does tell us something about the impact that healthcare providers can have on helping people to either prevent or delay type 2 diabetes by making those diagnoses and by referring participants to the class. QTech New York really is standing ready to help healthcare providers who have patients who are diagnosed with prediabetes. We want to help those folks to be able to find a class. We know that in the past, many people would get diagnosed with prediabetes, and apart from some counseling about what they maybe should do, there really wasn't some place to send people to help them to make the changes they needed to reduce their risk. So we've tried to develop this in a way that would help healthcare providers to access the program for their participants, but that could also kind of close the link between the sort of clinical community linkage. We know that what happens in healthcare providers' offices is critical, but we also know that patients make most of their decisions outside of the healthcare office. And that's why this community piece and these types of community-based programs are so critical to really changing the trajectory for many people who are at high risk of developing type 2 diabetes.
So what an excellent program. I'm glad we got to share that with folks.
Really exciting, isn't it?
Absolutely.
Yeah, it's very exciting.
Now, with all of that support, can you talk to us about some of the challenges that providers face in pharmacologic treatments for diabetes?
Absolutely, because I think there are quite a few challenges. Number one, and I have to make this point, none are FDA approved for use of treatment on prediabetes. So all the drugs are used in treatment of diabetes, but they're not approved by the FDA for use in prediabetes. And so many physicians, caregivers are appropriately wary of using them.
Sure.
They're expensive. They may not be covered by insurance companies because they don't carry a diabetes diagnosis. And every medication has side effects. So you have to make sure that the benefits outweigh the risks.
Absolutely.
Yeah.
And can you talk about some of the specific pharmacologic treatments?
Okay, sure. There have been about 4 or 5 studies that have been done. I think the biggest study was the King study, which was done in China, where they actually screened, only in China, 110,000 people.
Wow.
All over China. And they looked at those people who had prediabetes, and then they used lifestyle intervention, exercise, or diet, and they followed them along. And in fact, they found they could significantly reduce the risk of developing diabetes in this population. The other thing that I think is really interesting about this study is it also showed a decrease in eye disease from diabetes. So the patients who did well were at less risk of developing diabetic retinopathy, even while they had prediabetes or if they developed diabetes. So clearly an outcome benefit. So that also, they used a drug called metformin, which is probably the most common drug that we use to treat diabetes.
Okay.
It's got GI side effects, causes a little nausea, sometimes diarrhea, but otherwise easy to use. Acarbose has been used in stopping non-insulin dependent diabetes, which is the name of the study. Acarbose is tough to take because it causes a lot of gastric side effects, gas, and patients are hesitant about that, but it was also effective. Avandia is a drug that patients take once a day, not used as commonly now, but that drug was very effective in decreasing progression to diabetes. And then we look at weight loss drugs. So Xenical, Ali, people can buy that over the counter, and with weight loss, they found there was a decrease in progression to diabetes.
Excellent.
Yeah.
Now, can you talk about the research that's shown these treatments to be effective?
Right, so all the drugs have been found to be effective. I'd like to make the point of one. You see the pioglitazone drug there. In the study that was done called ACT Now, they actually found that in patients who had prediabetes, to slow the rate of progression to diabetes, it slowed it by over 80%. So that sounds like, wow, everybody should be on that drug.
Yeah.
And maybe that's true, but in fact, there's multiple side effects associated with that drug.
Okay.
So a lot of clinicians are fearful about using it. So it's always risk versus benefit.
Okay, and it's a tough
road.
And I would imagine varies very much by the individual patient and how great is the risk and what are the potential.
And in all honesty, many primary care physicians may not have the time or the ability to research it and feel comfortable with using these drugs when it's not FDA approved, and I can certainly understand that.
Sure.
Yeah.
So now, certainly though, there are promising results, and that's a good start for us.
Right.
What can healthcare providers do, given the information that you've shared?
Absolutely screen. If we don't screen, we won't make the diagnosis. We have to name this. We have to name it as prediabetes. It's not a little bit of diabetes. That's like being a little bit pregnant. It's a real disease, so we have to name it. Once we name it, we have to be aggressive about treating. Because one of the things they found is, we talked about the A1C being between 5.7 and 6.4 for prediabetes. Guess what? It makes a difference if you get their A1C to 6.2 or 5.7 or less than 5.7. And that difference is the higher the A1C, the harder to treat, and the more likely they will progress on to diabetes. So you want to be aggressive and aim for 5.7, which is different than the American Diabetes Association guidelines, which many clinicians are aware of. I think you really have to sit down with your patient. You have to be a messenger. Patients are asymptomatic. They don't feel anything. They don't want to treat something that they don't feel. So you really have to be a messenger about the power of prevention. And I think it's very important to tell your patients that you're referring them to a national diabetes prevention program, you have to tell them, this is important to you. You must do this. This will impact your life.
And I think one other thing, just kind of piggybacking off of what you said, is, people don't want to treat something if they're asymptomatic. People don't want to treat something that they don't recognize they're suffering from. But I think, you've talked about how the diet change and the exercise can be effective in treating. And I think that would be an important message, because you're not necessarily saying you have to take this drug.
Right.
And I think some people are really hesitant to take a medication. I don't want to take another pill. There are other options as well.
There's other options, and I think the value of these programs is, it's difficult for people without support to change their lifestyle. Everyone has barriers that must be broken down, and these programs really provide help in breaking down the barriers, no matter their ethnic background, whether they're economically challenged or not, where their community centers are, where they go. So I think that's important to note. And clinicians, providers don't have the infrastructure necessarily in their office to provide information to patients. So it kind of takes the heat off us that we can send our patients to these programs.
Sure. Now, certain actions can really take off when there is an established process in the office to diagnose patients who might have prediabetes. So can you talk about the SAFE process and what that stands for and what it looks like?
Sure. So SAFE, I think, is a valuable acronym. I think in medical school we have so many things to remember, and we remember them based on things such as SAFE. And SAFE means we have to screen. So S is screen. We must screen, and we talked about what the risk factors are and who we screen. Then once we've screened, we have to sit down with the patient, we have to talk to them, we have to assess them. What are their other comorbidities? They have hypertension, hyperlipidemia. Do they have underlying cardiovascular disease? And I like to make that point, because if you think your patient has silent ischemia or underlying cardiovascular disease, it wouldn't be a great idea to send them off to exercise 150 minutes a week. You might consider having to assess them, sending them to a cardiologist for a screen. And then you have to advise them. So you're advising them to go to the program. You may be considering medication. And then you have to follow up. So that's F, follow up. And E is evaluate their progress. Evaluating their progress might be getting reports back from the diabetes prevention program, seeing what they've accomplished, checking another blood work, seeing are they doing self-monitoring of blood glucose? Have they done a hemoglobin A1C? How are they doing? Are they accomplishing it? And I think when you follow this, what you're really communicating to the patient is, hey, this is important. This is important to you, and I am tied in to the benefit to you.
Excellent. Now, for providers who this is a new area for them and maybe they've not addressed it before, how should providers really communicate with patients about prediabetes?
Well, first they have to name it, as we talked about. So they have to say there is a condition called prediabetes. It's a condition. We have to be aware of it. We have to talk to patients about the risk. So we know that patients with prediabetes, 9% of them may be developing eye disease. Others are developing cardiovascular disease, risk for heart attack and stroke. So patients have to understand this is not benign. There are risks associated with it. We have to tell them what they can do. How can they prevent this? And I always do the good news, bad news. The bad news is you have this condition, prediabetes, but the good news is we have a lot of opportunity to stop you from going on to developing diabetes, and that's important for clinicians. If we don't have a diagnosis, we don't intervene, and we don't follow up. So we have to have a procedure.
So let's take a moment now to look at what a patient interaction in your practice might look like in having this conversation.
Okay. Kim, it's good to see you. Thanks for coming in today. I wanted to talk to you about some of the blood tests that we got back. Do you remember I did some fasting blood work on you and a hemoglobin A1C because you have that family history of diabetes and you had that gestational diabetes during your pregnancies? Well, I got the results back, and the results show you have prediabetes.
What is prediabetes?
Prediabetes is actually the step before diabetes. So what that means is your blood sugars are not completely normal, but they're not high enough to reach the criteria for diabetes. They're right in between. But what that means is it gives us an opportunity to intervene and stop them from going into the diabetes range.
How can I stop getting diabetes?
Well, you need what we call lifestyle intervention, and we're really lucky. We have a program in New York State called the Diabetes Prevention Program, and actually there's one locally at your community center that you can go to. And this program teaches you how to eat. They try to teach you and help you lose about 5 to 7% of your body weight. They help you exercise, and your goal is to exercise about 150 minutes a week. And what we found is if you do these two things, it actually lowers your blood sugar. And over years and years, your risk of going on to that type 2 diabetes is much, much less. So I have a brochure for you to look at. I want you to take a look at it. It describes the program. I strongly encourage you to go because I think it'll make a huge difference in your life. In fact, I've taken the liberty of signing up some information for you that you can bring to them, and it starts in another couple of weeks. So what do you think? Any questions?
That sounds great. It sounds like just what I need.
Yeah, I think so too. I think it'll make a difference in your life, and in fact, I'm going to have you follow up in about a month because I want to see how you're doing.
Okay, I'll be back.
Thank you.
I think that really is an excellent example that for other providers to see, how do you have these conversations, and certainly, especially the part at the end where you're going to follow up with the person. You're not just sending them out and whatever happens, but really taking it seriously. I think that's a great message to send.
Thank you, I agree.
So let's revisit that theoretical patient, AR, that you talked about earlier in the program. If you had screened and identified the prediabetes 20 years earlier, what would the outcome look like, and how would that be different than what you're seeing?
I think about that all the time. I think about if I had seen her as a younger woman, 20 years ago, what action could we have been taken? Well, we'd keep her hemoglobin A1C much lower. A1C 6.2, perhaps less than 5.7. If we were actually lucky enough to diagnose her during the pre-diabetes time period, she wouldn't have any of those complications. She wouldn't have retinopathy requiring laser therapy, painful nerve disease, underlying cardiac disease, kidney disease. She'd be 30 pounds lighter, which is healthier in every aspect of her life. She'd enjoy life more. So I think she'd have a greatly improved quality of life. And we have to think from an economic perspective. So from an economic perspective, her care and treatment would be much, much less.
Sure.
Yeah.
Sure. That's a very drastically different picture than what we're actually seeing.
And we have to be real, right? That's reality.
Yeah.
Yeah.
So New York State has taken great steps to address prediabetes, including developing a website and a campaign entitled 2 Million Aware by 2017. So can you tell us more about those initiatives?
Yeah, actually this broadcast marks the beginning of an exciting new New York State campaign called 2 Million Aware by 2017. This is an effort to increase the number of New York State adults who are aware of prediabetes diagnosis and to increase participation in diabetes prevention programs. An actual prediabetes toolkit containing the most current treatment, guidelines, and diabetes prevention tools will be made available in April of this year. So healthcare providers can be actually key leaders in the effort to meet 2 million aware by 2017. The toolkits will be distributed to healthcare providers throughout the state through academic detailing visits, so explaining it, by public health partners and local health departments and community-based organizations. So a wonderful, wonderful program that is progressing.
Excellent.
Yeah.
And as you said, we want to make people aware, because if we're not aware, we're not screening. If we're not screening, we don't identify, and then things just progress.
Knowing it is the first step.
Absolutely. And as we prepare to take questions, because we've got a number of questions from the audience, I just want to share with our viewer some information on how to ask questions with the New York State Department of Health and the QTAC program. That information is on your screen and also available in the handouts. So let's take a look here. We've got a number of questions that have come in from our audience. The first one says, we do serum level glucose testing. Can you elaborate on the plasma fasting glucose? And this is from Rihanna, who's an RN in Morton County Health Department.
Sure, easy. So fasting plasma glucose is probably obtained at the time of a physical. And so if a patient has it, right now, the American Diabetes Association criteria is if the fasting glucose is less than 100, the patient has no risks. If they're between 100 and 126, they have prediabetes, so you can diagnose that way. If it's 126 or above, then they have diabetes. But I want to make a point about that. And that is, remember we looked at the continuum from, you can't look at a glucose of 99 fasting and say, this patient is off the hook.
Sure.
A glucose of 99 would make me think, oh, this patient's at risk. Do I need to intervene now? Do I need to talk to them about it, maybe make some lifestyle changes, see if they are appropriate for a diabetes prevention program? So don't use hard and fast cutoffs. Look at your patient.
That makes a lot of sense. Now we've got another one. What can you say about the drug Invokana? The patient has been recently diagnosed with diabetes and HBP.
So Invokana is what we call an SGLT2 inhibitor. So it basically works on the kidney to cause you to pass more glucose in the urine. It has not been studied in prediabetes. It is very effective. Many studies done in diabetes, but no data in the pre-diabetes population.
Okay. And we have very good presentation. The question is, do you know of an electronic medical record template examples that help screen or flag for prediabetes to assist providers?
What a great question. So clearly we have to figure out a way to make it routine in our offices, particularly primary care docs who may have 10 minutes to see a patient and evaluate them. So right now, you can screen looking at blood work. So in electronic medical records, the blood work, hemoglobin A1C, fasting glucose is usually there and can be captured and give you a list of people who are within that pre-diabetes area. I think one of the things that we have to develop are screening questionnaires. So make a questionnaire, perhaps have it in your electronic medical record. It doesn't have to be done by you as the physician. It can be done by your medical assistant, nurse, and it should be intake. What's your ethnicity? Do you have a family history of diabetes? What's your BMI, if you know it? If not, measure it in the office. And that's another thing you can screen. So clearly BMI goes into electronic medical record. You can pull all those patients who have a BMI greater than 25 and look at risk factors. So I think as we progress forward, and prediabetes becomes more recognized, we will develop templates. And I think an important point is the diabetes prevention program is trying to find ways and working on ways so they can send us as clinicians information back on our patients that we send to them through the electronic medical record.
Sure.
So it gives us a way to follow up with the patient.
Great. Is the National Diabetes Prevention Program also available in other languages?
Yes, so there are, it's available in Spanish. So many of the local community organizations have people who speak Spanish, so it's available right now in both English and in Spanish. And that's important. And I think that the other point to make is not only language barriers, but educational barriers. So a lot of the material has been made up. So people who perhaps have not had as much education, maybe haven't even had a high school education, can understand the material and not feel fearful of looking stupid.
That's great. I think that's really important. We have another question. If someone is not overweight and already eats very healthy and exercises 150 minutes per week, but has a fasting glucose of around 106 for a couple of years, age 57, what do you recommend? Anything other than weight loss? And that's from Broome County.
Okay, so clearly I would have an assessment by a CDE, Certified Diabetes Educator, who specializes in nutrition, because even though they eat in a healthy way by their perception, it would be important to have an assessment and see if that was really true.
Okay.
So if once that was done, if they did clarify that everything was exactly as it should, then that patient might be a candidate to be started on medication to stop progression because they've already done the lifestyle things. And if their primary care doc or provider felt uncomfortable, that would actually be a reason for a referral to an endocrinologist.
Okay, excellent. We have another question. One provider recommends our DPP program to her patients, but she said that the 16 weekly sessions format is a barrier. How do you recommend that providers address that and insist that their patients attend? We tell people that committing to the diabetes prevention program is the equivalent to one day in their lives, just 24 hours. Any suggestions on how to communicate with at-risk people to convince them to attend?
I think you have to be direct. You have to say, you're at risk. So, if you don't do this, this is what will happen. Then you break down their barriers. Why is it too hard to do 16 weeks? What's getting in the way? Is it a problem with work? Or if they're unemployed, is it a problem with transportation? We find so much in prediabetes and diabetes that we actually have to sit and actually talk to the patient and figure out what's holding them back from achieving their goals. And sometimes, it's fear. If they don't talk about it, then they don't have to face it.
All right, we've got a few more here. Can you have a diabetes prevention program as part of a health system?
Yes, so I'm actually employed by St. Peter's Health Partners, and we have a program at Memorial Hospital that's associated with my endocrinology practice, and so I think that's a very important thing for a health program to have. We do have one locally here.
Great. All right, let's see. Sorry, they're flying in. I can't keep up.
That's okay. I'm glad.
How can county health departments be helpful in moving the dial in diabetes prevention?
That's an excellent question. And I think as a clinician, so I'm looking at it with the clinician hat on, we need to be made aware. So we need to be made aware of the information, the toolkits delivered, and then we need to know where the programs are, how we access them for our patients. What are the forms that we have to fill out? For any doc, it's all about time. So how can this be done effectively, quickly, make us aware, show us what we have to do? Perhaps in an office or a clinic, find what we call a champion, someone who will be responsible for that. So it's off the doctor's shoulders in terms of the scheduling and the follow-up.
Excellent. Let's see. I want to make sure I'm getting through. We've got that one. Now this one is a little bit different. In public schools across the United States, there have been policies and laws implemented to ensure that students have more balanced and healthy diets, and that's something we've talked about on prior shows. Have you done any research or have you seen any statistics that show federal meal plans in schools have a positive or negative effect on diabetes or obesity in adolescents? And I know you're not an epidemiologist, but maybe you could just speak generally if you have any thoughts.
Well, I think speaking about kids is important, and I don't have that data. I suspect it's there, but not being an epidemiologist, I haven't read it. I think the important thing to note is there are guidelines for children. So part of what's important for kids are these federally mandated meal programs as well as activity. We need to increase the activity that kids undergo during the day while they're at school, because when they come home, most of them just don't do that. So there are criteria set up by the American Diabetes Association, the American Association of Pediatrics, to screen for prediabetes, and that's kids who are age 10, who are overweight, who have a family history of diabetes, and the screening recommendation is to do a hemoglobin A1C. So if they're overweight and their A1C is between 5.7 and 6.4, they're considered to have prediabetes, and they need to move forward with further education.
And I think that is a very important point to make, because children, starting young and identifying early, I think probably we can't overstate the importance of that.
Absolutely true, yeah.
Well, we have covered a tremendous amount of information today, and I think you've done a great job of answering quite a few questions and really starting to really begin this conversation, because I think one of the things that you said that to me really stands out is you can't have a touch of diabetes, that prediabetes is an actual condition. And I think the conversation today really started to paint that picture and make that a more concrete and tangible diagnosis for people.
Well, I thank you for having me, because I think it's such an important topic, perhaps the most important topic we have right now.
Excellent.
Thank you.
Thank you. And thank you very much for joining us today. Please remember to fill out your evaluations online. Your feedback is always helpful to the development of our programs, and continuing education credits are available. To obtain nurse continuing education hours, CME, and CHES credits, learners must visit www.phlive.org and complete an evaluation and the post-test for today's offering. Additional information on upcoming webcasts and relevant public health topics can also be found on our Facebook page. Don't forget to like us on Facebook to stay up to date. This webcast will be available on demand on our website within 2 weeks of today's show. Please join us for our next webcast on February 19th, Confronting Health Disparities, Obesity and Prevention in African American Communities. I'm Rachel Breitster. Thank you for joining us on Public Health Live.